So now we'll go to the next session, which is talk about the new era in Cushing syndrome management by Dr. Anthony from the France.
Hello, everybody. I hope you can hear me. So it's my pleasure to participate to this BDER meeting, and I thank the committee for the invitation to speak on behalf of recorded rare disease about a new drug in the treatment of Cushing syndrome. So here is my disclosure. So as you know, the main goal in Cushing syndrome, whatever its etiology, is to remove surgically the original tumor. So unfortunately, this might not be efficient in some conditions. I'm trying to, I say I'm stuck with my slides. Oops. Unfortunately, sometimes surgery is not curative and you have to use medical treatment, or you have to use medical treatment as a bridge while waiting for a second surgery, or for example, for pituitary radiotherapy. And also in some instances, patients are in very bad condition and ineligible to surgery or need a pre-surgical treatment. So in this instance, you may have to use medical treatment for Cushing. So among the different classes of drugs, steroidenase inhibitors are probably the most potent one. So up to now, the main drugs were ketoconazole and metyrapone. You can see here the scheme of the adrenal steroidogenesis with ketoconazole that acts mainly on the 17 pathway, and metyrapone acting on the final pathways, the 11-hydroxylase pathway for aldosterone and cortisol synthesis. Osilodrostat, this new drug, acts at the same level than metyrapone. So what we know from this drug is that ketoconazole has major drawback of potent hepatitis, and it's a rare condition, but still 10 to 15% of patients, and is responsible for numerous drug-to-drug interaction. And the main drawback with metyrapone is the number of tablets to be taken. Aside these side effects, some others are expected from the mechanism of action of the drug. For example, ketoconazole that acts on the androgen pathway is responsible for hypoandrogenism in men, and metyrapone and possibly osilodrostat are responsible for an accumulation of mineralocorticoid precursor and also of androgen, so might be responsible for hypertension, hypokalemia, and hirsutism in women. So what are the main characteristics of osilodrostat? So from in vitro studies, we know that the drug is much more potent than metyrapone and ketoconazole in the inhibition of cortisol production in cultured cells. So what does that mean from a clinical perspective? Being more potent, that means less pills per day. And from the pharmacokinetic perspective, the drug is rapidly absorbed and acts very rapidly because, you know, after a single dose, the maximum reduction in cortisol is obtained at 12 hours. But the half-life is a little bit longer than that of metyrapone. And in practical terms, for the clinician, that means less intake of the pills per day. So here is summarized on this slide the different studies of the development program of osilodrostat that involve, as you can see, a huge number of patients, almost always patients with Cushing's disease. So I won't go into all the details of this study with different design. I will just summarize that, as you can see in blue, the majority of patients with Cushing's disease were controlled with this drug in terms of normalization of UFC and improvement in clinical symptoms, of course, and that the drug overall was well tolerated with adverse events that were expected based on the mechanism of action of the drug, and more specifically the accumulation of adrenal precursor. So I will just illustrate with you the efficiency of the drugs that I was able to use very rapidly a long time ago in different situations. I will start first with a case of Cushing's disease in a 30-year-old woman who came to our department with large spontaneous fluctuation in hypercortisolism intensity. She had a normal pituitary MRI, but Cushing's disease was proven by bilateral sinus sampling. And it's common practice in our department to perform pituitary surgery, even if pituitary MRI is normal. But unfortunately, in this lady, surgery was unsuccessful. And so we had to consider second-line pharmacological treatments. So at that time, the lady was enrolled in a study, Novartis study, with the use of pasireotide long-acting drug. But as you can see, after 5 months of treatment, she was still very hyperkalemic with a UFC that was almost 3 times the upper limit of normal range. So she was then prescribed metyrapone, and due to our clinical condition, we rapidly increased the dosage up to 2 grams per day. 2 grams per day of metyrapone means 2 pills at wake up, 2 pills at noon, 2 pills at 6 o'clock, and 2 pills at bedtime. So quite cumbersome treatment. But despite this relatively high dose regimen, as you can see on the graph, UFC level remained above the normal range that is represented by the shaded area. So the drug was not very effective, and we really suspected the patient to be non-compliant with the treatment. So at that time, we were able to enroll the lady also to use Osilodrostat and to enroll in a study. And as you can see, we start with 2 milligrams twice a day. And after 1 month, she had dramatic decrease in her UFC level, is the blue columns, but UFC was still above normal. This is the normal range, is the blue area. And we increased the dosage up to 5 milligrams per day, 5 milligrams twice a day, 10 milligrams in total. As you can see, during almost more than 1 year, UFC was perfectly controlled. Of course, at the same time, as you expect with the drugs that block adrenal steroidogenesis, we observe an increase in plasma ACTH level. But importantly, after, you can see, more than 1 year of treatment, as the UFC level was rather low, and the patient felt mild clinical discomfort with asthenia, neutral asthenia, and she had an ATM serum cortisol that was close to the lower limit of normal range. So she was on the way to experience adrenal insufficiency. And this is an important point to consider, that this drug is very effective, and as it is effective, it can induce adrenal insufficiency. So in the LINK-3 study, you can see that almost half of patients experienced some degree of hypocortisolism, but it was severe in only 10% of cases. So you can see also on the graph that it occurs mainly during the titration period, but it can also occur after weeks of treatment. So this is a very important point. In my view, it's not a salutary effect. It's an expected effect showing that the drug is very effective. But you have to consider that and follow your patient closely in terms of clinical symptoms and also in terms of ATM cortisol, because you know that UFC is not a very sensitive tool to diagnose adrenal insufficiency. As you can see in this lady, we were able to decrease the drug dosage up to 3 milligrams twice a day, 2 milligrams a day, and down to 1 milligram daily, while maintaining for years control of UFC. And after some time, by the end of last year, UFC slightly increased again, and we had to re-increase the drug dosage up to 3 milligrams per day. So this is very important to consider this lady, because it's a very unique case of long-term treatment with the drug, showing that the drug can have an increased efficiency with time, but also that you have to follow your patient regularly, because at some point they may experience either adrenal insufficiency or a re-increase in UFC. What about the clinical part? Of course, the normalization of UFC was as expected, accompanied by clinical improvement, as illustrated by the picture of this lady, which is much more happy than when she came for the first time. And in terms of tolerance, I will emphasize 2 points. First, as you can, because we talked about the precursor, accumulation of precursor, and you can see that despite an accumulation of aldosterone precursor, blood pressure remained always normal, and kalemia indeed improved a little bit with time. She had some hyperkalemic hypokalemia at the start that was treated by potassium supplementation that we could stop after some months of treatment. And as you can see also, intriguingly, in terms of hirsutism, the Ferryman score decreased with time. So it was really on the opposite to what we can expect based on the mechanism of action of the drug. And if we look at her testosterone level, you can see that at baseline, she had firstly an increase in testosterone level that decreased afterwards to remain slightly above the normal range. Assuming that the patient lost some weight, we can also expect that the concentration of sex-binding globulin increased and that the free testosterone level could normalize. And interestingly, this was observed despite persistently increase in the CTH level. So this intriguing phenomenon has also been observed in the LINX-3 study and has to be more studied in future study, but apparently hirsutism might not be a frequent complication of the drug treatment. Of course, we were concerned by the increase in plasma CTH, huge increase, and we followed very regularly pituitary MRI, but as you can see, despite huge level in the CTH, we did not observe any change in tumor. No adenoma was visible even after 5 years of treatment with the drug. In terms of precursors, there was also, of course, an accumulation in the immediate precursor to cortisol, 11-deoxycortisol, with a brisk increase after start of treatment that tend to decrease with time, but still remain elevated. So this is an important point to consider, because you know that 11-deoxycortisol has no clinical effects, so it's not important from a clinical perspective, but it's more important from a biological perspective. Indeed, we have here a slide drawn from a study with metyrapone, because as the drug acts at the same level, it increases the levels of the 11-deoxycortisol. And you can see that the issue is that, 11-deoxycortisol can cross-react with assays to cortisol. You have here in a patient the level in 11-deoxycortisol that increase with the dosage of metyrapone. You have here the cortisol measurement with a regular immunoassay, and here with a very specific assay, a mass spectrometry. And as you can see, with immunoassay, your level of cortisol measured are artificially increased. So I don't mean that you need to have a spec mass assay, but it means that you have to discuss, as for metyrapone, when you use this drug, you have to discuss with your biologist to know which assay he is using and to know that it can increase artificially a little bit the level of cortisol either in the serum or in urines. I want to mention some personal experience about other situations than Cushing's disease. And we published some cases, for example, of ectopic CTH syndrome that you know is characterized by the huge, intense hyperplasm. This is a case of a patient who had a small cell lung carcinoma. She was treated and controlled for ectopic CTH syndrome with 2 milligrams per day of Osilodrostat. But due to regrowth of the cancer, there was a recurrence of hyperplasm. And you can see here a huge level of a serum cortisol, more than 1,000 nanomole per liter. Of course, this huge hyperplasm was accompanied by diabetes requiring insulin treatment, increase in blood pressure, hypokalemia requiring supplementation in spironolactone. And here we used an increased regimen quite different from the LINX study in the sense that we acted very rapidly and rapidly increased drug dosage. And as you can see here, within 2 weeks, we were able to control fully the disease, to have a normal serum cortisol level, and of course, regression of all the cortisol-induced comorbidities. I will just also mention another situation, quite rare situation, but very complex. It is the case of adrenal cancer. We perform a short French survey of 7 patients with advanced CCC that were treated with a drug. 5 of these had an intense hyperplasm, that means UFC more than 5 times the upper limit of normal, or serum cortisol above 1,000 nanomole per liter. And these patients that were treated in different ways, so we can see that we were able to obtain a dramatic decrease in UFC, and of course associated with an improvement in the systolic blood pressure, regression of hypokalemia, and in this patient we were also able to withdraw hypertensive drug and also to withdraw potassium supplementation. In summary, we were able to obtain the control of hypertension in the 7 patients involved within 3 months and even within 1 month in 3 of these. The drug was well tolerated, and again, we observe here mainly 3 cases of mild adrenal insufficiency, especially during the occurrence of sepsis in 2 of these patients. And we know that in this condition, the body needs higher levels of cortisol. So here is the summary of at least my personal experience. Actually, I need to update this camembert because we have treated now more than 24 patients of different etiologies of Cushing syndrome. And in our experience, as in the LINK study, we were able to control Cushing in much more than 80% of patients with a reduced number of pills. As you understand, it's very important to consider the possibility of adrenal insufficiency due to the effectiveness of the drug. That means teach your patient, teach the MD, follow the symptoms, follow also ATM cortisol, and not only in the short term, but also in the mid and long term. But as you have seen, the drug is overall well tolerated with some expected side effects like hirsutism that seems to be less frequent than expected. So this is something to be confirmed and also to be studied in terms of mechanism. It's important, very important, as with methylropon treatment, to discuss with your biologist in order to know exactly what assay you are using for cortisol measurement and what is the degree of cross-reactivity with 11-deoxycortisol. And also in some situation, specific situation of very intense hypertension, you need to reconsider the dosage and titration strategy that is recommended for the common cases of Cushing's disease. So I have now finished my talk. I thank you very much for the invitation and the attention. These are some pictures of Bordeaux, and I'll be to take some questions if there are in the audience.
Thank you, Professor. That was a very nice review. This is our second talk today about Cushing syndrome, and I think there is no questions right now. I really thank you that you are with us right now, but we're concluding the session. We're moving on to the next one. Thank you very much.
Okay, thank you. Thank you.